and to thank the organizers of the meeting for inviting me to speak. So I'm going to be talking about the assessment of iron status. It's become increasingly controversial. We've had a number of these parameters around for a while. In fact, to prepare this talk, I actually dug into a talk I gave at ASN in 2006 in which many of these same issues were addressed. So to a certain extent, we're still grappling with some of these controversies regarding assessment of iron and therapy with iron products for our patients with anemia related to their end-stage renal disease and dialysis. So reminding you what transferrin saturation is, again, this is probably one of the most commonly used tests of iron status. It's the serum iron divided by the total iron binding capacity. Most of that iron binding capacity in the circulation is transferrin. As you also are probably aware, there is some acute phase reactivity based on this transferrin level. Transferrin levels tend to be low in malnutrition and chronic disease, transferrin being a protein, so chronic disease and nutritional adversity will impact on all protein synthesis, including transferrin. And there's also significant fluctuations in the transferrin level that are diurnal or based on other factors that may affect the transferrin saturation based on the underlying transferrin level. As you can see here, if you look at categories of malnutrition, if the TIBC actually will decrease in states of severe malnutrition. And when you apply this to dialysis patients, and remember that the TSAT is the serum iron divided by the TIBC, if the TIBC goes down but the patient has the exact same amount of circulating iron, this will lead to a perceived increase in the transferrin saturation. So again, we have to interpret levels of transferrin saturation in the setting of the patient's overall nutritional and medical status. What is the appropriate transferrin saturation target in our patients with chronic end-stage renal disease and dialysis? This was a study that Tony Besserab did in the late 1990s after the original DOPPS anemia guidelines were released, which, as many of you who were around at that time recall, recommended a transferrin saturation target between 20 and 50%. Now, this is a very wide range, so Dr. Besserab decided to try to dissect down that range to see whether patients did better at the upper end of that range with a transferrin saturation of 30 to 50, or at the lower end of the range, which would be a transferrin saturation of 20 to 30. And as you can see here now, in a prospective trial, he found that the ESA responsiveness was much better when the TSAT was maintained between 30 and 50. This was an observational study that was done by Cam Kalantar-Zeta on the DaVita database, looking again at the odds ratio for responsiveness to ESA, and what he found again was that a transferrin saturation of greater than 30% gave the best ESA responsiveness. Let's shift a little bit to ferritin. Ferritin, as you're aware, is a protein with a very, very high molecular weight, almost 500,000 Daltons, which originates from the reticuloendothelial system and is produced mainly in the liver and in erythroid cells. So erythroid precursors actually have some ferritin with which they can store iron and ultimately transfer it to hemoglobin synthesis. This functions as an iron-binding protein for storage, and we use the serum ferritin level as a marker for storage ferritin, which is within the tissues. Serum ferritin is not a transport protein. It does not contain any significant amounts of iron. And the term henoacidurin, which many of you are familiar with in terms of a histologic finding, is actually condensed ferritin molecules which have bound their iron. So the presence of henoacidurin in a tissue is not necessarily a measure of iron toxicity or tissue damage, because the ferritin has essentially contained that iron and prevented it from being toxic to the tissue. So serum ferritin results from the leakage of tissue ferritin. Here's a cartoon that shows you the iron contained inside the ferritin shell, so you can think of it as a Tootsie Roll pop, with the iron inside being the chewy center and the ferritin itself enveloping it like the candy coating. And as I said, serum ferritin contains little or no iron, and what the role of serum ferritin is really not well understood. Next slide. Can we get the next slide? There we go. Okay, so serum ferritin ultimately, like any other serum level, is going to be the balance between its appearance, which is due to secretion or leakage from tissue ferritin, and its clearance, which is mainly in the liver, and therefore liver dysfunction and inflammatory factors may interfere with either the synthesis or the disposal of ferritin, and thereby increase serum ferritin levels independent of iron status. This is another Kallentar zetagram, if you will, based on the DaVita database, showing again the odds ratio for responsiveness to ESA actually peaking at what many of us would consider to be a relatively high serum ferritin level of 800 to 1200. This is another observational study that was done by the folks at the University of Louisville, where again they looked at ESA responsiveness, and that's the term on the y-axis, based on serum ferritin levels and on transferrin saturation. And as you saw with the Kallentar zeta data, there seems to be a peaking of responsiveness to serum ferritin at somewhere in the neighborhood of 400 to 600, with a relatively plateau effect till about 1,000, and then a significant fall off. At that point, the high serum ferritin level probably represents an inflammatory issue and issues with mobilization of iron. And again, with transferrin saturation, you see a peaking at around 30%. So what about CHR? This was not part of the talk or my charge in discussing assessment of iron status, but I couldn't resist mentioning it because this is something that has been mentioned in the literature and is actually contained in the KDOQI guidelines as an alternate to transferrin saturation. This is a more real-time assessment of iron status. It actually measures the incorporation of iron into reticulocytes, which, as you know, are the red cells that are 1 to 2 days old. So if you backtrack the production of red cells, you're basically talking about iron mobilization and delivery to the erythroid marrow that occurred about a week or so before the CHR is obtained. It can actually be performed by a hematology autoanalyzer. Multi-channel analyzers have this already built in, so you just have to ask for it. The machine already does it, and there may be an additional charge of about $4, not very expensive. As I said, it's recommended by both the KDOQI and the KDIGO as an alternate to TSAT in assessing the iron that's actually available for erythropoiesis, but unfortunately, despite a fair amount of literature showing that it may actually have higher sensitivity and specificity for EPO responsiveness than TSAT, it's achieved very little utilization in the United States. These are two of these studies that were done in the late 1990s and early 2000s, comparing the sensitivity and the specificity of CHR to the traditional serum ferritin and TSAT. And as you can see in both of these studies, the CHR actually had a superior predictive value in terms of responsiveness to IV iron. Okay, let's go to the next slide. We seem to have a little hang up here.
Right click, if you see the mouse, right click on the mouse. Or left,
right clicking on the mouse.
Bring the cursor
there we go.
over to
Here's the mouse again.
There you go.
Okay, all right. In another study of CHR in 157 patients treated with IV iron dextran, which was the state of the iron art at the time the study was done, you can see the patients who were in group 1 were treated with serum ferritins of less than 100 and TSATs. The patients in group 2, they used a CHR of less than 29 and a subset of less than 30, and they found that the CHR was actually less variable and more accurate than using the TSAT and the ferritin, and in a subsequent study they actually found a better utility when a CHR cutoff of 32 was used. Now let's shift a little bit to current data. These are the DOPPS data, the Dialysis Outcomes Practice and Pattern Study that has been done in the United States for the last several years and is actually also being done in several other parts of the world. This is a stratified random sample of dialysis facilities in the U.S. that report all of their data, including anemia parameters such as hemoglobin, ESA use, serum ferritins, transferrin saturation, and this is a voluntary study. So the facilities that participated and submit their data in a timely fashion, and most of these reports, which are available online, are no greater than about 4 months old, which is significantly more current than the USRDS data that's usually more than 2 years old. So you can see these data that I recently downloaded from the DOPPS site are as recent as March of 2015. If we look at the hemoglobin values among dialysis patients in the United States, you can see that there was a significant reduction that occurred in early 2011, which was corresponding to the onset of the bundle payment, as well as the FDA label change for ESAs, which changed the target hemoglobin from 10 to 12 to basically a ceiling of 11 and no floor. And as you can see here, there was a significant reduction in mean hemoglobin levels from around 11.5 to about 10.8, and that 10.8 has remained relatively stable since about 2012. If we look at monthly IV iron dose in the same period, you can see there was somewhat of a little blip in the late 2010-2011, as many U.S. dialysis facilities were anticipating the onset of the bundle payment, and they were looking at IV iron as an ESA cost-sparing strategy. Of course, IV iron being relatively less expensive than ESAs, so the perception being if we can achieve the same hemoglobin with more IV iron and less EPO, then we can save money that way, and let's do it. Following that, and again, following the decrease in the target hemoglobin level that went with the change in the FDA labeling for ESAs, the IV iron dose returned to its baseline level, which, as you can see, is about 200 milligrams per month or about 50 milligrams per week. If we look at the TSATs over that period of time, you can see it was also relatively stable at around 30%. There may have been a slight drift up to maybe 31 or 32%, but again, you can see it's been more or less stable at around 30% for the last 5 or so years. On the other hand, the serum ferritin levels have gone up significantly from a baseline of around 600 in late 2010 to approaching 800 in the early part of this year. Now, this serum ferritin obviously is a concern to many people, and as I showed you, the mean hemoglobin levels decreased from around 11.5 to 10.7, which is around a 7% decrease in red blood cell mass. The iron doses, as you saw, have remained relatively constant at around 200 milligrams per month. So the question is, if less iron is going into the red cells because the red cell mass is decreased, where's the rest of that iron gone? Why haven't we proportionally decreased the iron doses to that lower hemoglobin target? Is this rise in serum ferritin a new problem? Is it dangerous? And what is iron overload, and what is the relationship to, if there is iron overload, to this change in practice in terms of IV iron and hemoglobin targets? Now, putting that serum ferritin in a larger chronological framework, you can see here that this rise in serum ferritin is not a new problem. It has actually been going on continuously since 1991, 2 years after ESAs were released in the United States. And again, these data come from different data sources, and Dan Coyne was able to put these all together to show what's almost, if you squint a little bit, a linear increase in serum ferritin levels among dialysis patients in the United States over the last 20 to 25 years. And you can see the most recent serum ferritin level from the DOPPS data is around 820, meaning half the dialysis patients in the United States in 2014 had a serum ferritin of greater than 820. The DOPPS folks were also intrigued by this phenomenon, and they tried to dissect out how much of that change in serum ferritin is due to the change in anemia practices and how much of it is unexplained. So I apologize that this graph is a little on the small side, but again, you can see that iron doses remained relatively constant between 2010, after a little blip in early 2011. The serum ferritin has gone up, the hemoglobins have gone down, the ESA dose has gone down. Then doing a multivariate analysis, they looked at how much of the rise in serum ferritin is due to the changes in ESA use and in iron use, and what they found is that there's a significant portion, almost 50% of that rise in serum ferritin that is unexplained and totally unrelated to anemia management practices. So you can speculate, well, are dialysis patients sicker, more inflamed, have higher hepcidin levels, more iron is now being trapped in the RE system and less being released to transferrin and erythropoiesis, but the answer is we just don't know for sure. So that shifts us to a question is, what actually is iron overload? As we mentioned, iron is stored in the RE system, which reside in the liver in particular as the Kupffer cells. Increased iron content in the liver on MRI studies, which has been a recent finding, may be a physiologic reflection of increased storage iron in the places where it actually belongs, namely the RE Kupffer cells, and not necessarily spilling over to the hepatocytes where it may actually produce liver damage or functional abnormalities of the liver. As we said before, since hemosiderin is actually condensed ferritin molecules, increased hemosiderin on a biopsy of the liver may actually be a physiologic or benign reflection of increased storage iron and not necessarily a marker for liver damage. If we look at hemochromatosis as a model for iron deposition in the liver. And of course, we all understand hemochromatosis is a progressive state of iron accumulation because of lack of hepcidin, so patients absorb much more iron in their diet than they can excrete, and ultimately it overloads the tissues. What they find by doing serial liver biopsies among patients with hemochromatosis and correlating it with their serum ferritin levels at the time is that serum ferritin levels do actually reflect the iron burden in the tissues, but iron overload with actual organ damage does not occur until patients have had hemochromatosis for greater than 40 years with greater than 20 grams of parenchymal iron storage. So hemochromatosis in patients with severe fibrosis or cirrhosis actually end up having a mean serum ferritin level of almost 4,500, which is far in excess of the 820 that we showed you is the mean for dialysis patients in the United States, and a TSAT of 91%, which is also far in excess of the mean transferrin saturation levels in dialysis patients of 30%. There's actually no evidence of cirrhosis in hemochromatosis patients with serum ferritins that are less than 2,000. So what about the MRI liver content in dialysis patients? There have been several recent studies that have looked at content by MRI, and they've classified as less than 50 micromoles per gram as being normal, 50 to 100 being mild, 100 to 200 being moderate, and greater than 200 micromoles per gram of liver tissue being severe overload. Not surprisingly, at least in my opinion, MRI liver content most closely correlates with serum ferritin level and with cumulative iron dose. This was a study that was published in 2011 looking at serum iron markers as a correlate for liver iron concentration based on MRI, and as you can see here, there's really very little correlation with transferrin saturation, very little, no statistically significant correlation with serum ferritin, but there was a statistically significant correlation with the cumulative iron dose, not based on ferritin or TSAT, and with the dialysis vintage. In other words, the longer you're on dialysis, the more likely you're getting IV iron, and therefore the greater likelihood you are to have a larger cumulative iron dose. This is another study that was published just last year looking at the maximal standard dose of parenteral iron, and they did an MRI-based decision tree learning analysis. And what you see here are patients who had what they considered to be iron overload on MRI, and I showed you the mild, moderate, severe parameters in a couple slides ago, yes versus no. And as you can see, again, there seems to be a correlation more with the IV iron cumulative dose, the iron per month, than there is with any of the serum iron parameters, be they serum ferritin or TSAT. What I found surprisingly was that there was not more of a linear correlation, a greater likelihood of IV iron overload with iron dose per month, and that there actually at any given iron dose, say at 200 milligrams per month, which is a typical iron dose as we saw in the United States, there actually is a significant proportion of patients that don't have hemochromatosis, or I should say hemochromatosis, but MRI findings of iron overload at that same dose. So again, it's relatively slippery, in my opinion, to be able to correlate even IV iron dose with the presence of iron overload on MRI. Now, in Europe, there's been a recent change in anemia practices. There was a European best practices publication in 2013 that significantly decreased the targets for both transferrin saturation and for ferritin. Prior to 2013, Europe went with the KDIGO guidelines that recommended a ferritin target of 300 to 500 and a TSAT target of greater than 30. In 2013, I guess as part of this iron concern of iron overload, they made much more conservative guidelines and actually recommended that the transferrin saturation be maintained less than 30 and that the ferritin be maintained less than 300. So what they did is they looked at patients who were in an original cohort based on the original KDIGO practice guidelines, and then another cohort that was done subsequently whose iron therapy and anemia management was based on these newer, more conservative iron guidelines, and they looked at their liver content. And as you can see here, there was in fact a shift in the liver content, the original cohort in blue here being more likely to have higher levels of liver iron content than the patients in the newer content, which had much more conservative iron management parameters. In another study by the same author, who apparently is really into MRIs of the liver in patients on dialysis, they again looked at patients who were just started on dialysis and then received IV iron over the course of 3 to 6 months, and then they compared their liver MRI content before and after the routine administration of IV iron based on the facility protocol. Again, this was done primarily by the KDIGO guidelines, and not surprisingly, most of these patients had a rise in their liver iron, and then they took these same patients, actually it was another cohort of patients who had been treated with IV iron, had elevated liver iron content, they took them off their IV iron or significantly reduced their IV iron dose, and again, this led to a significant reduction in MRI liver content. So again, most of these studies seem to indicate that it's not necessarily the TSAT or the serum ferritin that's associated with iron content, it's actually the dose of iron that's being given. So just to summarize, serum ferritin and TSAT are imperfect predictors of iron status, response to iron therapy, and whatever we're talking is iron overload, and I put it in quotation marks because I think if you ask any 10 people in this room what their definition of iron overload is, you'll probably get 10 different answers. Despite its greater sensitivity and specificity in predicting the hemoglobin response to IV iron, CHR has had poor uptake in the United States, and again, these data have been around for about 15 years, and yet no one really seems to feel that CHR is worth shifting to. The sweet spot for iron responsiveness based on the observational studies, as well as the DRIVE study that was also mentioned earlier this morning, seems to be at serum ferritin levels that are associated with increased liver iron content in MRI, raising these concerns about, quote, iron overload, whatever that is, and ultimately more research is needed to assess the risk and benefit of iron dosing regimens. And just these are research recommendations that appeared in a Jason white paper last year regarding trying to sort out all of these issues of the risks versus the benefits of IV iron. Again, conservative versus liberal dosing strategies, high priority, probably needs a randomized controlled trial. Bolus versus maintenance dosing, probably are RCTs with larger studies than have been done in the past. High versus low threshold for IV iron administration. Again, yes, we really need to revisit that because the DRIVE study really has not had a lot of traction and still raises a lot of concerns regarding the higher ferritin levels that were a target in that study. Ferritin versus TSAT, again, probably observational as well as RCT studies. EPO sparing versus IV iron sparing strategies. IV iron strategies versus oral iron, now that we have novel oral iron agents, and ultimately a comparison of different brands of IV iron in terms of bioavailability. So that concludes my comments, and I thank you for your attention.